Thank you.
I will.
Good morning, Randall and Dean. Welcome. We'll be starting at the top of the hour.
Good morning.
Good morning, Russ and Karen. We've got lots coming on. Give folks, just a few more minutes here.
Good morning.
Hi, everyone. We're just going to wait a couple of minutes before we get started. This is Elke. So hold tight if you're already on. Thanks.
Natalie, I'm going to call you.
Okay.
Hello, everybody, and welcome. This is Patrice Burgess, the chair of the group, and thanks so much for your attendance on this happy Friday. And we have a lot to go through, so I am going to keep moving along. So, Elke, did you want to say hi to everybody?
I did. Thank you, Patrice. I know someone is advancing the slides for us. We go to the next one. It's basically just are welcome. So I am Elke Shaw-Tulloch, and I am the Executive Secretary for those of you on whose first time this might be on the committee. And Dr. Burgess and I is kind of co-facilitating this along with our facilitator, Monica Rabosi, will be leading you through things. So thank you.
So next slide, please. Just to kind of level set, this should all be familiar to everybody, but we're just going to go over our purpose real quick. Remember, we're advising the governor and assisting. And so prioritization of the vaccines when they're in limited supply is a lot of what we've been spending time on. And then implementing the vaccination plan and communication, delivery of the vaccine, and making sure that we have equitable access across the state. So just kind of level setting what our priorities are. Next slide, please.
And today there are a few things that we're going to be getting into with you all. So we're going to go through our final recommendations on the goals, principles, and our healthcare personnel rankings that we talked about last time. We have some questions that Dr. Burgess and I will be posing to you around vaccine communication and any support that you may all need. And we'll be reviewing that next priority group that you'll hear in some presentations. And I wanted to take a moment just to pause on the fact that this is a huge reminder that this is a rapidly changing landscape, as you all are very much aware, as you're reading in the news every day that there's something coming up and changing in the vaccine world. So with that, just that reminder to you all that while we're pushing to encourage you all to make some tough decisions on ranking of classifications and groupings of people and things like that, and who will be prioritized for the vaccine. Just your reminder that as things change, we may have to come back and make some changes, or there's new information that will come along that we want to make sure we get to you so you have the most current information available to make some of these decisions and make it recommendations back to us. So that's just a little primer that, while we're going through all this and asking you to make decisions, that at any given point in time, as we learn more about the vaccines and the rollout, the recommendations that are going to be coming out of the ACIP and others, that we may have to then kind of reconnoiter and pivot on some decisions that we've already made. And I also want to remind everyone that all of our meetings are open to the public, and the public will be coming on as an attendee versus a panelist. And those folks that are participating as an attendee and members of the public are certainly open to providing us input as well. We are accepting public comments through a specific email account that you can see on the bottom. And in case you happen to be listening in and not viewing this slide, the address is all spelled out, COVID, the number 19, vaccine public comment at hw.idaho.gov. So make sure that you submit any comments that you have, and we want to make sure that we get those comments at least 24 hours before the start time of any meeting.
And Elke,
yeah,
sorry to interrupt. This is Angela. We're in the process of moving a number of the members up from the attendee list. They came in.
Great, thank you.
We're working on that. Thank you.
Okay, thanks. And for those members who have submitted emails to me only, I'm making sure that I'm forwarding them to the team so they can get you pulled up into the panelist list. So next slide. And I think we're moving over to Monica.
Thanks, Elke. Good morning, everybody. Thank you for being here today. I'm going to quickly get us set up for the meeting. Instead of doing roll call today, we have so much to cover. We're going to do just an attendance acknowledgement, which means if you could take a look at the list of participants on your list of names on the side to just take a look at who's here today. We are, as Elke just said, moving some folks from attendee to panelist. That sometimes happens, so we're remedying that. So we should have a complete list in just a few minutes. I just wanted to mention that Ann Lawler will be attending for Dr. Steve Malik, representing the Board of Medicine today. And we may have a few folks joining us later in the meeting who had some conflicts. So keep your eye on that list. And thank you again, everyone, for being here today. Is there anyone else who's a designee who we have not already been informed of ahead of time that we should know? If you'd like to put that in the chat, that would be helpful. And with that, I'm going to move forward and do a quick review of the agenda for us today. We could have the next slide. Thank you. So we are, after we're done with this section, we're going to move right into hearing from Dr. Burgess on the finalization of the Idaho vaccine program goals, principles, and healthcare personnel rankings. And that will be followed by a presentation from Sarah Leeds on some new developments in the vaccine world. So initial regional allocation of doses for phase 1 healthcare personnel. We had a small change from the agenda that went out on Monday in the meeting package, and that is we're simply going to ask voting members to weigh in on the question that you see on the slide here at the bottom with regard to a distribution plan for initial vaccine allocation. So be ready for that, but you'll hear lots of good background information from Sarah first. We have the next slide. Then for the second half of the meeting, we're going to turn to that item that we've been trying to get to, which is very important, and that is how to communicate what's going on with regard to the vaccines to the various groups who will be receiving the vaccine. And because we are starting with the healthcare personnel, we're going to focus on that for today with the understanding that we will expand this conversation to all groups and all priority groups as we move forward. We're just prioritizing time-wise here. So we'll be asking some of those questions that you see there. Then we'll hear some updates with Dr. Bridges on the vaccine and move right into discussion of sub-prioritization of the next vaccine priority group. So we'll hear lots of good information there, and then we'll let you know what our next steps will be so that we can continue to move this forward quickly. Any questions on the agenda before we move forward? And please feel free to use the chat as well. We're not going to go over the ground rules today, but they are at the bottom of your agenda, so I encourage everyone always to take a quick look at those as we get into the meeting. And if we could have the next slide. Very quickly, this is just our orientation to our various functions. I'm sure just about all of you are very familiar with these by now. We have the mute, unmute. Of course, please try to be mindful of muting when you're not speaking. If you can have your video on for the meeting, that would be fantastic so we can continue to see one another during the meeting. If you would like to comment when we have discussion time, there's the hands up function, which is to the right of your name in the list of participants. We have the chat, of course, underneath that list of names. We have a little picture here showing where the quick feedback button is, which we used once last time, which is that megaphone button, which is right underneath the list of names and above the chat. So that's for quick feedback where we can say yes or no in response to specific questions that we might be asking. And that if we have polling, which we're not anticipating specific polling today, but you'll see that pop up like we did last time below the chat, I believe, if there's a need for that today. And with that, I believe I have covered all the overview for our meeting today, and I'd like to pass it over to Sarah Leeds for a presentation on regional vaccine dose allocations.
Actually, I think I'm first, just to go over our decisions that we already made, and then Sarah's right after me, I think. So, was somebody saying something?
No, go ahead.
Oh, okay. So we have already made quite a few decisions. I'm going to go over those and just kind of also level set that the process we did, I think, was good, and we came to a lot of good decisions, but we're going to have to move more quickly now that the vaccine timeline is more quickly. So what we're going to do is review the decisions we've already made. And then, as Elke mentioned, if we get new information that dramatically changes anything about what we've already made, we'll go back and revisit those. But we also have to keep moving forward. And we're going to do our best to give you guys all the information that we can, and then again, ask you to do your homework between meetings by responding to our request for prioritization votes. And then we will review the results of those at the following meeting, and try to keep moving so we can get all of the business done we need to get done and get to the some of the practical decisions that we need to make. So next slide. So these are our goals. You remember we had done a little wordsmithing together, and you had all let us do the wordsmithing beyond that between the meeting. So the red words you see here are what we added based on the feedback. So, and the economy was addressing the concerns about that particular bullet point. And then appropriately, there was concern about equitable distribution, making sure that we added within the prioritized groups. So we added that. And then the final bullet we added was around transparency, as there was a lot of discussion about making sure that we had something listed there. And so that's the bullet that we added there. So hopefully that meets the needs of the folks that raised those issues, and we really appreciate the discussion that we had. And feel free to make any comments in the chat, but we will consider this to be final as we've kind of had this discussion on 2 or 3 occasions now. And this incorporates all of the comments that we received by chat, by email, verbally, and even we review the public comments as well. So next slide, please. The principles, there were no changes to these, both in our discussion and between meetings. So we will keep these same principles. I'm not going to read through them because we have read through them before, and we have a lot of really important information to discuss today, but just a reminder that none of them changed. Next slide, please. And this was our final ranking. And so interestingly enough, it also did not change. So if you remember, we had an email vote between the first meeting and the second meeting, and then we had a very robust discussion during our second meeting with some additional information, concerns from the different subgroups. And then we did another vote in between the second meeting and this meeting, and the results as far as the ranking came out exactly the same. So these are our final rankings, unless we get some significant change of information from the Advisory Committee on Immunization Practices, which are doing their own evaluation, and they're a group of experts. So if they came up with something different, we would probably want to come back and revisit. But for now, this is our grouping, and we'll look at some more numbers later, but depending on the volume of activity, it would potentially cover most of these groups, and particularly if not everyone wants the vaccine. So I think the good news is we should be pretty well covered, and we eventually will get enough vaccine to vaccinate everybody that wants the vaccine. Anyway, this is the final ranking, and just wanted to share that with you, and this will be available on the website, I believe. And so next slide, please. Now we get to go to Sarah's presentation. So take it away, Sarah. Thank you.
Well, this is Elke. I'm going to step in here because Sarah is experiencing some technical difficulties trying to get on the call. So we're going to, in the spirit of being flexible, we should have our picture of Gumby on screen. I think we are going to transition and see if Dr. Bridges could start her presentation a little earlier, and then we'll just come back. Dr. Bridges, are you ready to do that?
Yep, absolutely.
Thank you.
Thank you. Okay, so just to reiterate, we are now going to be moving to talking about prioritization or sub-prioritization among phase 1B. Next slide. Before I do that, I just want to provide a little bit of an update about the 2 vaccines that are closest to being available. We have the Moderna vaccine and the Pfizer-BioNTech vaccine. Both of these are mRNA vaccines. The Moderna vaccine is 2 doses, with the first dose or second dose 28 days or more after the first. And Pfizer, the second dose is 21 days after or more after the first dose. They have different storage and handling specifications. The Moderna vaccine is shipped -20, and they recently announced that that vaccine can be kept at refrigerator temperatures for now 30 days. So that definitely helps with some of the logistical considerations. It is shipped as a frozen liquid. It does not need to be reconstituted. The Pfizer vaccine ships on dry ice, and then that dry ice needs to be recharged in the shipping container once it arrives. If the vaccine is not put into minus 75 degrees right away, it is shipped in trays of 975 doses per tray. You can have up to 5 trays per shipping container. And the vaccine is stable at refrigerator temperatures for only 5 days. But those shipping containers can be used, I believe it's up to 3 recharges. But you have to open and close the box very quickly, no more than twice a day, less than 1 minute per box opening if you're storing your vaccine in those containers. The next slide. We've had some very exciting news about some of the clinical trial results from both of these vaccines. The Moderna vaccine, they announced in their preliminary look at their data that the effectiveness is 94.5%. They saw mostly mild adverse events that the grade 3 events, those are events where someone was not able to do their usual activities. That's how FDA defines grade 3. And those grade 3 events, about 10% had fatigue, about 9% had muscle aches, about 5% had joint pain, about 4.5% had headache, and about 4% had pain. They also noted that they had no severe illnesses among vaccine recipients. 11 of the placebo recipients, which was saline or salt water, 11 of those had a severe illness, and they had no severe illnesses among vaccine recipients. So that's fantastic news. For the Pfizer vaccine, they had, again, mostly mild to moderate. Their grade 3 events that were greater than 2% of the study population, 3.8% had fatigue, and 2% had headache. Of the 10 severe cases that they noted, 9 of those had received placebo and 1 received vaccine. So these are extremely comparable vaccines in terms of this preliminary effectiveness data and safety data. So really, really exciting stuff. It's like landing on the moon. It's that exciting. Okay, next slide. So Sarah was going to show this slide too. I'll just reiterate that what we're talking about right now is phase 1 of vaccine, when we know that vaccine is going to be in limited supply, but we expect over the next several months that supply will increase to the point where we will be able to expand vaccine to larger numbers and more diverse groups of people. Both manufacturers have recently provided updates on their websites. Pfizer expects 50 million doses for the U.S. During 2020, and Moderna on their website says they expect 20 million doses in 2020. So again, recalling that that's enough for about 35 million people if everybody gets their 2 doses. Next slide. So just before we get into our discussion of subprioritization for phase 1B, I just wanted to reiterate the goals, both from CDC as well as the Idaho goals. So the CDC goals are to ensure safety and effectiveness. Right now, Idaho is not doing a separate review. We have FDA and CDC and many others doing that safety and effectiveness review. The other CDC goal is to reduce transmission, morbidity, and mortality, to help minimize disruption to society and the economy, including maintaining healthcare capacity, and to ensure equity in vaccine allocation and distribution. The ethical principles that CDC and ACIP are applying are to maximize benefits and minimize harms, to promote justice, to mitigate health inequities, and to promote transparency. Next slide. So we've just gone over these goals, or Dr. Burgess already went over these goals, so I will not repeat those. Next slide. So these are the main large categories of groups that initially were proposed by CDC as being in phase 1B. As Elke noted, the CDC and ACIP continue to meet. They're actually meeting on November 23rd. So that's just next week. And we expect that they are going to further address prioritization of vaccines. So we will, as she noted, want to keep you informed of any additional decisions that CDC makes in this regard. But based on what CDC has proposed and talked about in their meetings thus far, these are some initial categories for consideration. So I provided some estimates for Idaho population. I just want to reiterate, these are rounded numbers. They are not precise. They are estimates. So the major categories are adults 65 and older. There are around 280,000 people in Idaho who are 65 and older, and that number does include long-term care facility residents. There are around 371,000 adults 18 to 64 years of age in Idaho who have one or more recognized high-risk condition for severe COVID, and that number is based on an assumption that about 35% of adults in this age group have one or more high-risk condition. That number may be slightly lower or higher, but we're using 35% as a planning assumption. And then consider essential workers who are not in phase 1A. So these are essential workers who are not healthcare workers. They're already covered in 1A. There are about 450,000 essential workers not in phase 1A. And this assumes, and these are planning assumptions, there's not precision here, but this assumes that about 24% of all essential workers are healthcare personnel, based on CDC's estimates of about 21 million of 87 million essential workers being healthcare workers. And this assumes that the healthcare personnel population in Idaho is around 106 to 116,000 people. One other group for consideration is essential workers that have a high-risk condition. So essentially, we would take that 450,000, assume that about 35% of that population has one or more high-risk conditions, and you're left with about 157,000 people who are non-healthcare essential workers who may have one or more high-risk conditions. So these are just ballpark rounded estimates for information and planning. The next slide. So these are the groups that we're talking about in terms of critical infrastructure sectors. This is a large list. Next slide. And I just highlighted a few where they have been brought up at the ACIP meetings as being of a particular focus. Corrections and food processing are both critical infrastructure areas where there have been significant outbreaks, where social distancing and PPE have been more challenging and where we have seen significant outbreaks. Another one highlighted is education, obviously, because we had a lot of discussions about the potential role of schools being open in their contribution to community transmission, and of course the critical role of schools. And then other commercial entities, and by this I mean those other essential worker groups where they have high exposure to the public. So people who work in grocery stores and convenience stores and other places that serve the public in high numbers. Next slide. So similar to the healthcare personnel, thanks to Chris Carter and others, we're working on estimating Idaho populations. Again, it's difficult to come up with these numbers with a high degree of precision. So these are estimates, and they're likely to change as more information becomes available. The groups that we've been able to break out here, considered for phase 1B, include residents of long-term care facilities, around 12,000 people, adults 65 and older living in the community, adults with high-risk conditions. I've talked about these groups before. At one point, there was some discussion about breaking out adults 50 to 64 based on their increased risk of hospitalization, first responders, EMS, again, as a reminder, is included in 1A. So these are other first responders other than EMS, about 22,000. Teachers, including daycare, and this is my error. It should be staff, education staff, not just teachers, but other staff as well. And then food processing workers, around 35,000. Grocery store convenience workers, about 29,000. Idaho National Guard, about 6. And correction and detention facility staff, around 3,000. And estimates of other essential working groups are under development or in progress. Next slide, please. Other groups for consideration include incarcerated persons. Again, as I mentioned, they obviously cannot socially distance, and there have been significant outbreaks in these kinds of facilities. Persons living in migrant housing, that's about 18,000. It can be in more chronic conditions. Homeless persons, obviously a number of challenges there, about 5,000 people. Family caregivers of persons at high risk. This is a more difficult number to come by, and there's quite a range depending on how you define that. About 83,000 persons who are voluntary caregivers were provided with respite care services. And based on the behavioral risk factor surveillance system survey, they also provided a percentage of adults who help care for a family member. And if you use that percentage, the estimate is around 286,000. So that's quite a range. There are also people of different racial and ethnic groups that appear to be increased risk. And for Idaho, that would be a group of about 325,000 adults with conditions that might put them at risk. So these are other conditions that there might carry an increased risk of COVID complications. That's about 900,000 people. And then people with disabilities, around 241,000. Next slide. So CDC has looked at data on a more national scale, trying to help us understand risk based on these various factors. More cases occur in younger persons. However, as we've all noted, the percentage of death, the risk of death increases with age. And there are certain high-risk conditions that appear to increase the risk of hospitalization. And those can go anywhere from a risk potentially increase of 1.5% for asthma, up to 4 times increased risk with chronic kidney disease, 4.5 times risk with severe obesity, and if you have 3 or more conditions, 5 times increased risk. So many of these conditions go together. Many people who have one of these conditions will have additional high-risk conditions. Next slide. So looking at data from Idaho specifically, again, we see that the number of cases, and I would just reiterate, these are numbers, not rates, but the number of cases are more likely to be in younger people, with the greatest number of cases among the 18 to 29 year olds. If you look at the blue bar graph, hospitalizations, that graph shifts, so we now see higher numbers of hospitalizations in older adults. And then if you look at number of deaths, more of the deaths certainly are mostly in our older adult population as opposed to our younger adult population. We've had no deaths in children. Next one. So if you look specifically at Idaho data and the relative ratios of hospitalizations and death by each group, if you look at the 18 to 29-year-old as the comparison or sort of base case scenario, then the risk of hospitalization for adults, for example, 80 and older, is 15 times higher than that of 18 to 29-year-olds. And the risk is even lower than 18 to 29-year-olds for 0 to 17-year-old, also for children. If you look at the far right column at the relative risk of death, the risk of death compared to 18 to 29-year-olds is over 1,000 times higher for people who are 80 and older, and 280 times higher for adults 70 to 79. And you can see how those relative risks relate to each other based on age group. Next slide. And then this is CDC data. They looked at the risk of hospitalization, and then they looked at the risk of hospitalization, of death, among persons who were hospitalized. So among hospitalized persons, again, using the 18 to 29-year-olds as the base case comparison, again, they actually found quite similar numbers to what we did in Idaho for both hospitalization. Their relative risk of death is a bit different because they only looked at death among persons who were hospitalized, whereas the numbers I showed you for Idaho were all. Next slide. And lastly, CDC looked at the relative risk of hospitalization for different racial and ethnic groups. I do not have data to show you specifically for Idaho, but overall that they found a 4 times increased risk of hospitalization among non-Hispanic, American Indian, or Alaska Natives, non-Hispanic Blacks, Hispanic and Latinos compared to whites, and compared to non-Hispanic whites, the risk among non-Hispanic, Asian, or Pacific Islanders was 1.3 times higher than whites. Next slide. And now I'm going to turn over to Elizabeth Wakeman, who is the ethicist on our committee. Thank you, Elizabeth.
Yeah, hi. I teach at the College of Idaho and been teaching ethics and bioethics since '92, and since '94 serving on the West Valley Ethics Committee. So I want to talk about just dealing with ethics and moral dilemmas. I'm among the group of philosophers who think that they're real, which is to say that sometimes there are not right answers. All the answers are bad, and none of them is right, is good. And so we have to cope with it. And sometimes that's hard, right? And a lot of you are making these decisions daily in your lives, and I recommend that you take care of yourself and give yourself the room you need to cope with that. It gets a little bit easier if we get a little more distance from it and think about how ethical decisions are made. There are 2 components, the facts and the values. And a lot of these slides are giving us the facts. the epidemiologists give us the facts. And as I understand, we need to concentrate mostly on the values, which are also the priorities. Now, we've got goals, but right now they're all the same. And so if we think about our goals and how to prioritize those, that will help. Next slide. So I put our goals up here, and this is from our older set. They're not precise. But equity and transparency, that's for everything. But then when we get to these other ones, recovering of society, reducing transmission, functioning of the healthcare system, they are interconnected, right? If we reduce transmission, then so that it's not going out of control, then society gets better and the healthcare system is a whole lot better. If we reduce death, one thing is better. So they relate to each other. But if we still decide what we're going to prioritize on this short list, it can make these decisions faster, right? We can ask for the correct facts. If we vaccinate this group before that group, how will that affect reducing transmission, for instance? So if we focus on the goals, it can be easier, not easy, but at least it can be simpler and gives us a path and allows us to make decisions without everybody fighting for their constituency. We want to, right? We're here to represent people and we want to advocate for them. But as a group, we'll make better decisions if we concentrate on what the goals are and we consider how to rank the goals. Thank you.
Thank you very much, Elizabeth. Okay, this is now, this starts the hard part. I prefer the facts. And there are a lot of facts that are missing for us to fill up a grid like this. So what I did was develop a grid with those potentially prioritized groups on the left and the goals, or way to think about those goals on the top. This is purely a draft. It's for illustration purposes only. And please don't concentrate on the degrees of gray, because it is a there are degrees of gray here in making some of these decisions. So this is just one way to think about it as a potential tool for the committee to see if this would be helpful as a way for them to think through this extremely difficult decision. So I'm going to go over the way that I was thinking about this as a potential tool, and then we'll go into discussion. So across the top are the goals, and I assigned relative levels of gray to each of those categories based on how potentially vaccinating that group met that particular goal. So I'm just going to go through a few examples here. So residents of long-term care facilities. If you think about reducing transmission, one of those issues of transmission are the number of individuals that they have contact with, and how crowded their living conditions are. So I think vaccinating long-term care facility residents would meet that goal of reducing transmission. And similarly, they have a difficult time socially distancing, and many patients in nursing homes obviously can't wear PPE. So that helps address that transmission issue. Preserving society and the economy does not apply as much to vaccination of long-term care facility residents, but the goal of reducing severe illness and death, about half or so of our deaths in Idaho are in long-term care facility residents, so preventing deaths in that group would help meet that goal to a significant degree. There are definitely access and equity issues for long-term care facility residents who are a very vulnerable segment of our society, and by preventing severe illness in long-term care facility residents and reducing the risk of outbreaks in long-term care facilities, then you're not transferring high-risk persons to the hospital, and you also have room in long-term care facilities for hospitalized patients to be transferred to, so that preventing illness and severe disease in those residents also helps us with that goal of preserving functioning of the healthcare system. So with each of these different groups, you can go through these different goals and think about how well or to what degree vaccinating that particular group meets that goal. I'm just going to go through a couple of other examples, and this is, again, this is a draft, and it's really just a tool, but everyone should fill this out the way that they think it should be. So, for example, first responders, they can be exposed to a lot of people, obviously, and it can be very difficult to socially distance. They do have access to PPE, which is helpful. Obviously, they have a significant role in preserving the functioning of the society. They are not, as a group, necessarily all of them at greater risk than their age, same age cohort, and they are important for functioning of the healthcare system. Another group to think about is teachers. Schools are some of the most, if not the most densely populated facility anywhere in any community. They have a very challenging task of socially distancing. They can't wear really N95s all day with students. Their work impacts a large proportion of society, and vaccinating them helps preserve the economy and functioning of society. And in terms of the healthcare system, of course, we know that many parents are unable to work, including healthcare workers. If schools are not open, they don't have daycare available. Food processing workers is another example, detention facility staff, Idaho National Guard, and others. So next slide, please. So now I just want to blank those grays out and let each of our voting members, think about potentially using this kind of a tool for them to make some of their determinations about how well vaccination each of these individual groups helps fulfill or meet the goals of the Idaho Immunization Program. Next slide. Some other groups for subprioritization in 1B may include, for example, incarcerated persons. We've had a lot of outbreaks in these kinds of facilities, inability to socially distance, etc. And of course, there are significant issues with access and equity, and nationally, certainly, and in Idaho, there is a higher proportion of incarcerated persons who may fit into those racial and ethnic and other groups where equity is certainly something we need to remember. Persons living in migrant housing, obviously more crowded, inability to socially distance, homeless persons, again, high numbers of exposures, potentially limited ability to socially distance, access and equity issues, family caregivers of persons at high risk. They may not have as many contacts in that particular role as being a caregiver, but it's very challenging to socially distance when you're trying to be a caregiver for a high-risk person, and maintaining these high-risk persons in their own home certainly helps maintain societal functioning and protects our healthcare system. And when these high-risk persons or family caregivers get sick, then they certainly are at risk of transmitting and causing severe illness and death in their high-risk family member. Racial and ethnic groups at increased risk. Obviously, there are some access and equity issues that we certainly need to consider there. And as I showed you in an earlier slide, many appear to be at increased risk of hospitalization. And there's a disproportionate percentage of people in many of these racial and ethnic groups that work in some of those high risk areas of essential workers that have been more hard hit during the pandemic. And then we have adults who have conditions that might increase the risk, as opposed to conditions that have been more stronger data about the increased risk. And then persons with disabilities, who we should also consider as a separate group who have access and equity issues that we should consider as well. Next slide. And again, now you should forget about those shades of gray that was the draft, and think about how each of the committee members may want to think about those relative contributions to vaccinating those groups in terms of meeting Idaho's goals. So I think I will stop there. We can have some discussions as to start this very difficult discussion. As Dr. Wakeman noted, I think we want to just keep in mind these are extremely difficult discussions that no one likes to have. But we also want to keep in mind that our vaccine supply is going to increase over the next several months. And so that will allow everyone to receive the vaccine over the next several months for anybody who wants to be vaccinated. One way also to frame these considerations is how can we best maximize the benefits of the vaccine and minimize harms. Considering Idaho's vaccination goals and principles, it'd be helpful to know what additional information there is that might be available that we could help you with your decision making. As Dr. Wakeman also mentioned, are there goals or principles that the group feels should have more weight than others? And are there risks that should be more heavily weighted potentially than others? So the risk of severe disease versus the risk of exposure versus a group's role in societal functioning. And again, we would be open to input about what other formats it would be helpful for you to see some of this data and information in terms of helping you make decisions.
Thank you, Dr. I just wanted to jump in. Thank you for being flexible and moving your presentation up as well. A lot of important things to consider here. I just wanted to jump in and say we have about 8 minutes or so for this initial discussion right now, just to kind of set that expectation. Would you like to open it up for feedback and questions right now?
Yeah, that'd be great. And Elizabeth, any other comments you have from an ethicist point of view?
Yeah, I noticed something about unhoused people. I had put on my slide that equity always mattered. And I hope that what we do is that as we consider a various group, like people with medical conditions, we address in some ways equity issues if we pay attention to things like transportation. So a lot of the people who have access issues, who are unhoused, who work in our farms or who live in migrant farmer camps, people who are disempowered in society in different ways, often they don't need their group as a group to be put somewhere. But what they do need is to make sure that when their group that they're in is being vaccinated, like people in food service or food production, that we have figured out how to get the vaccine to them and get them to the vaccine.
So, thank you.
Monica, do you want to help facilitate that discussion, or how would you like to?
I'm just noticing we have a few comments coming up in the chat, and I haven't seen any hands up yet. but perhaps I know we have a couple of folks monitoring our chat for us. Are we ready? Are there any questions specific to this discussion in the chat?
This is Kathy. So there's a couple of points about, there was a question about whether or not the military are being vaccinated within their own system. And I just want to point out that the Department of Defense does have their own vaccination program. INL was thrown in there, but INL is the Department of Energy, so would not fall into the Department of Defense. Then there was a question about selecting individuals that will be immunized if the person is already positive or have been found to have antibodies, and whether or not the recommendation would be to immunize everyone. Dr. Hahn, do you want to comment on that one?
Yeah, I did respond in the chat that the expectation is that people will certainly not be tested prior to vaccination. It'll probably be recommended for everyone, whether or not they believe they might have been infected in the past. Obviously, we'll wait to see. And then there's some really great comments. People might want to look at Dr. Keller and Josh DeWalt from Department of Corrections. Has some very good comments. And Carolyn, I don't know if you're able to see, to glance at those good points about people in custody and how they are being considered. Obviously, they present a lot of risk to introducing infection into the community, the people working in those facilities. And then lastly, I'll just comment on the very last question, which is about, have we done any surveys to know what percentage of eligible people will take the vaccine? Carolyn, I know you're well aware of some national surveys that have been done, and there is some work in Idaho to look, at least among healthcare workers, what the uptake might be. But there are some good national estimates for using for planning purposes.
Yeah, this is Carolyn. One of the predictors of vaccine uptake is vaccine effectiveness and safety, and we're just getting that data that I shared with you earlier in my presentation is just starting to become available. I think some of the estimates are around 50% uptake, but a lot of that data was before some of the vaccine safety and effectiveness data was starting to become available, and I suspect that we'll see more interest in the vaccine as data is available for people to review and feel comfortable with it.
Dr. Bridges, we do have a hand raised by Jeff Keller, although I see it just went down. So, Jeff, did you have a comment or a question?
Yeah, well, I had a comment, and the comment is that studies have been done on influenza immunizations in nursing home populations, and I don't have them right here in front of me, but basically what it says is that you get more benefit for the residents by vaccinating the people who work there than you do by vaccinating the residents themselves, although it is important to vaccinate the residents themselves too. And in a prison population, as Josh DeWalt pointed out in the chat, it's important to where COVID is coming into the correctional system is through the people who work there. So they are really high, should really be high on the priority list. That was my point.
Great. Thank you, Dr. Keller. And I think we'll be very interested to know when the data is available what the vaccine effectiveness is in older adults. I think that will certainly help with some of the discussion.
Do we have any other comments either in the chat or hands up? I don't see any hands up at the moment, but anything else that we should bring forward at this point as we wrap up this segment of the meeting?
Monica, there's nothing additional in the chat right now.
Great, thank you. All right, well, certainly there's a lot to think about here. And Dr. Bridges, would you like to wrap up this discussion and talk about what's next?
So I think I'll turn over to to Elke and Patrice to talk about how they want to move forward, but certainly we will be wanting to get your feedback via email, both from the public and from the working group members. We anticipate, as I think we said earlier, that the ACIP will be meeting on November 23rd, and when we have that information, we will forward it on to the committee for their information as well.
Yeah. Thank you, Dr. Burgess. This is Elke again. So I'm jumping in on top of Patrice here. I think as we're trying to coordinate the next level of events, we're going to jump to Sarah to give her overview, because some of that will help inform the dialogue as we move into that stage of dialogue.
Thank you, Elke. Next slide, please. So the topics I want to talk about with you all today are just clarifying the purpose of early distribution. As everything we're dealing with in this effort happens, we learn things and then it gets clarified. And so since I talked to you at the last meeting, some things have changed in terms of our clarity of the purpose of early distribution. I'm going to talk very briefly about provider enrollment and our first phase of that, and then talk about initial dose allocation. Then we are going to ask you for, we're going to request a recommendation. We're going to pose a question and it'll be a yes/no answer. And then just have, after that, a quick slide about some considerations that we'll be planning for over the next 2 weeks with our vaccine planning team, and probably have some information more at the next meeting. Next slide, please. So the purpose of early distribution of vaccine, and this, again, I just want to remind folks about the process. Any vaccine manufacturer will, and this we're talking in this case specifically about the Pfizer vaccine, which is the ultra cold vaccine. CDC asked states to, if they would be willing to identify 1 to 5 sites with ultra cold freezers where they could distribute the vaccine after an EUA is issued, and the time in between before an ACIP recommendation for the vaccine. And again, ACIP is the Advisory Committee on Immunization Practices, and we don't administer vaccine until this committee, ACIP, makes a recommendation. So we anticipate this might be a few days, but we just don't know. So the purpose was for a few providers to get vaccine and have it ready so that when the Advisory Committee on Immunization Practices makes a recommendation, those providers could start to vaccinate ahead of time, just to get a sense of the cadence of what it will take to vaccinate people with this new vaccine and the storage and handling complexities it presents to us. And again, just emphasize that the timing difference in vaccine administration between early distribution and when ACIP makes their recommendation and we start shipping regularly to providers is about 24 to 48 hours. And so just to give you a heads up that, or an update, that we are working with providers, more and more providers are getting some access to ultra cold freezers, and we are working to make sure that every region in the state has 1 tray of the Pfizer vaccine for early distribution. Next slide, please. So this graph shows, excuse me, how we are ramping up and planning for phased approach to COVID vaccination. Right now, we are at that ramp up stage in phase 1, and that is when there is limited doses available, and we are really, there's a tight focus on vaccine administration, and we are focused right now on phase 1A. And as more doses become available, and potentially we think Moderna is going to be available very soon after the Pfizer vaccine, and it potentially could be available roughly at the same time, meaning that we would be flexible about rolling through phase 1A a little quicker and into phase 1B. And there's a lot of factors that depend on that, but I just wanted you to see this slide to kind of anchor you into where we are with our phased approach. Next slide, please. So as the immunization program is enrolling providers, we are heavily focused right now on ensuring that the providers who would be vaccinating those in phase 1A are enrolled. And right now, we think those are public health districts, hospitals, and federally qualified health centers. And again, I just want to emphasize that these would be the vaccinators, not necessarily the people to be vaccinated. And then right now, we are focused on vaccinating with our first allocation, those highest ranked in the phase 1A, which were healthcare workers as inpatient facility healthcare workers and long-term care facility staff. We've got 3 scenarios that we're working with and planning for. The first one is the Pfizer ultra-cold vaccine. The timing of this graphic is a little off because we're saying the end of November, and what that realistically is like is going to probably be mid-December. But the doses available around the country remain the same. They're anticipating 10 to 20 million doses. Next slide, please. Excuse me. So the next scenario is one that it's an unlikely scenario, but it's not an impossible scenario in that we get the Moderna vaccine first. We do know that in the news today, it was announced that Pfizer will put their application in for an EUA, but Moderna may be very quickly behind them. So we anticipate when Moderna is approved for an EUA, there will be around 10 million doses around the country that will be allocated. And next slide. So this scenario is one we're really looking to plan for now, is having both vaccines at roughly the same time. We think Pfizer might have a few weeks ahead of, we might be dealing with Pfizer for a few weeks before Moderna, but again, this is also speculation. So if we have both allocated or approved at the same time and we get an allocation across the country, these are the doses that we're looking at, 20 to 30 million in a mid to late December. Next slide, please. So again, just to summarize, it could be a few weeks of the scenario 1 with just the ultra cold Pfizer vaccine. Then it could be then followed by scenario 3, which is then both. A few weeks of Pfizer, then we're dealing with both. And it could be scenario 3, which is both at the same time. And we're trying to be prepared for all of these scenarios. And we continue to enhance our plans daily for these scenarios. So unofficial numbers of initial doses, and just to give you an idea of what we have put together, we'd originally heard 60,000 doses, then it was 47,875. Yesterday on a call with CDC, we were told there could be a range of 52,000 doses of Pfizer, maybe as low as 31,000. So just to give you a sense of how we're looking to roll out this initial allocation, we're saying potentially it could be 52,000 doses roughly. And according to the way we've in Idaho ranked our subgroups, we would be targeting vaccination provided to inpatient healthcare workers and long-term facility staff. So if we take regional distribution through our public health districts 1 through 7, and the providers throughout those regions, we look at the population of healthcare workers and long-term care facility staff. The breakdown of percentage is in that second column of the table. So, Public Health District 1, there are approximately, of the total healthcare worker, inpatient healthcare workers and long-term care facility staff, roughly 14.7% of them are in District 1. And as you can see, you go down. District 2, 7.3, and on and so on. So if we take the 51,975 doses, which would be 53 trays, because again, the trays, the shipment, the minimum shipment right now for the Pfizer vaccine is 975 doses in one tray. And one tray is the minimum shipment. These are the number of trays that would be in there. So this is a rounded number of doses for the percent of healthcare workers, if that makes sense. And so this is how we are proposing that we would distribute vaccine regionally. Next slide, please. So with all that information, I'm sure there's some discussion and questions. And just to let you know, after this, there's 2 more slides. The next slide is a question that we're going to ask you through a poll. And then the final slide after that is just some additional things to consider as we continue planning, and we'll present again next week, 2 weeks from now.
Okay, this is Dr. Burgess. Before we go to that, I'm going to ask our chat monitors if there's anything we need to address in the chat.
Yeah, actually, there is a question in the chat, and the question is, could you confirm that a dose refers to both injections when 2 are needed?
Great question. Yes, that's a great clarification. When we say if CDC gives us 52,000 doses, there will be another 52,000 held back for that second dose.
Thanks, Sarah. Another question that has come up is, how will we know which vaccine is best or most effective for particular populations? Are both of these vaccines equally as effective or safe for all populations?
I want to defer on that. I don't have that information in front of me. I don't have safety data. I'm going to ask either Dr. Hahn or Dr. Bridges. Do you know better do you know more?
Sarah, I don't know if Carolyn's unmuted, but basically the safety data is not available yet. We do have some preliminary information with Moderna saying that they're not seeing safety problems, but it's certainly FDA or the trial observers would have halted the study if there were serious safety concerns. But basically, we're waiting for the safety data. And that similar question about best or most effective in different populations. Again, we need to wait till there's more data available. We just don't know that yet.
Thank you, Dr. Hahn.
Yeah, but Sarah, this is Carolyn. Just one other thing, that both vaccine manufacturers have data up on their websites. It's publicly available. That's the information that I put in my slides about the 2 vaccines. That's about the extent of what's publicly available at this point.
Thank you, Carolyn. Sarah, the other question is the state going to provide freezers to the public health districts?
Yes, we have purchased 7 ultra cold freezers, and the health districts now have the opportunity to say yes or no if they want those. But yes, we have purchased 7 freezers for each region.
Thanks, Sarah. One question is, do you have the total number of healthcare workers and long-term facility staff in each of the health districts? Follow-up, what percentage of people who could be in phase 1A would this amount of vaccine cover? The 50-ish thousand doses.
Sorry, this is Carol, and I do have a slide in the extra part of my slide deck that may help with answering this question, not by public health districts, but by the state. I don't know if that would be helpful.
Yeah, go ahead, Carolyn. I have that, and I just need to find it. It's on one of my windows that's open, but go ahead. Okay. If you have a total, I have it by district if I can find it.
Maybe while we're looking for that, Sarah, one question is, will phase 1 vaccinators like federally qualified health centers be asked to vaccinate in long-term care facilities and hospitals?
We are going to be working with the public health districts over the next couple weeks to ensure what those plans are. So there'll be a little bit of a localized approach to that, and we are working to ensure that we support the districts in their work, and we know what's going to happen there. So I don't have the exact answer, but yes, we are working to ensure, and that's why we've asked federally qualified health centers to enroll.
Great. And then along those lines, Sarah, a question from Nikki Chopsky is, how are community partners being identified? Is there a mechanism for them to volunteer? Would that be the public health districts as well?
It would. I'm assuming that's to be vaccinators, helping vaccinate.
I would presume so.
Yeah, yeah, that's a local level issue as well. And again, we're working with them to, think those through.
Okay, and then the last question in the chat so far is, does the National Vaccine Injury Compensation Program also cover this vaccine?
So this is not part of the National Vaccine Injury Compensation Program, but there is a mechanism for injury compensation. And I'm not sure if any of our, if there's additional information from some of my colleagues.
Maybe, Sarah, we can take that back and send out the information to the group.
Sounds good.
Thanks.
So I do have my information up about the total number of inpatient healthcare workers and long-term care staff, and that total is 56,396. So this 51,000 would not totally cover them. And if we have a lower allocation than that, there'd be a lot that wouldn't cover, but the 52,000 would be close. And just to give a kind of a little disclaimer, this data is 1 year old, and we anticipate updated data at the end of this month for this total. So we're going off 1 year old data.
Okay, thanks, Sarah. One of the questions in the chat was, does the state already have the freezers, or are they on order? With the note that this person had ordered a freezer, but they're on back order. Sarah, I know you know the answer, so I'm going to kick it to you.
Yeah, so we ordered the freezers. Our preparedness program ordered the freezers, and they are anticipating an arrival date in Idaho around December 7th. And then what we are doing is kind of tracking them, and then because they're shipped in one shipment, and then we will organize the shipment out through a shipping company, and they will go out to each health district the next day. So we anticipate right now, with current order tracking information, districts could get those by December 8th or 9th, potentially.
Great, thank you, Sarah. Another question, and this is about the pharmacy program. The question is that we mentioned earlier that long-term care facility residents would be vaccinated by Walgreens and CVS as part of the pharmacy program. And the question is, how will they do this? And so if you could provide any, I know that program is still being worked on at the federal level, but the details that you know, Sarah.
Yeah, I'm sorry. I'm such a visual person. I usually need to, it helps me to see the question. Or could you reread it, Kathy? I'm sorry.
Oh, absolutely. So it's about long-term care facility residents being vaccinated by Walgreens and CVS. And the question is really about how will this happen?
Okay, thanks. So for the facilities that selected to be in the pharmacy partnership program for long-term care facilities, which is Walgreens and CVS doing the vaccination, Idaho, and I think every state across the country has opted to be a part of that program. We could have chosen not to. We chose to be a part of it, and we will work in concert with CDC as we go through our allocation. We will say when to kind of quote turn on the pharmacy partnership program, and so as those doses are used, they will be deducted from the state's allocation. And so when we're ready for that phase to begin, we will make a decision, and in all likelihood, you all will be involved in that as we decide when to turn that on as a state, and then start having the long-term care, the Walgreens and CVS have access to the state allocation of doses.
Thank you, Sarah. I want to ask our chairs if there's any hands up. I can't see the hands because I've got the chat window open. If not, we'll continue looking at chat.
Kathy, this is Angela. No hands now, but we might need to keep moving on the agenda and come back to chat.
Yeah.
Yep.
I think
to the
while
chair.
we're working on, this is Dr. Burgess, while we're working on the chat, maybe we could go back to Sarah's slide that has the question that we want to ask. And then while we're getting back to that slide, oh, that was quick. If we need to get to any of the other chat questions, we can either do that maybe at the end, or we can even do that by email. So just to kind of summarize, we kind of ended up going backwards. So this presentation was really to kind of explain what's going on with the vaccine availability and the districts. And then Dr. Bridges' presentation was our next job of looking at sub-prioritization within Group 1B. So just to try to kind of keep in mind the overview of what we're doing. So right now, looking at this question is really how does this group feel about the decision to allocate the doses that we receive according to the health districts, knowing that our 1A prioritization groups are the healthcare workers and long-term care facilities. And Elke or anybody else, feel free to chime in if I'm not framing this properly. And this would be if we receive a shipment, we think it'll be about 52,000, but we could be more. But basically using the philosophy of these percentages based on the health districts and the percentage of folks in 1A that are in those health districts. Anybody want to add to that question before we take a vote? Did I frame it properly?
I think you did great.
I see a nodding head. So remember the little megaphone above your chat and below the list of participant names. So please just do a little yes, no, if this seems like the appropriate philosophy for how to distribute the vaccines among our health districts. Again, this isn't prioritizing groups. This is just saying where the vaccine would be distributed. And then later we'll be talking about going to our 1B group. So yes or no if you agree with this percentage distribution model.
for the voting members.
Yes, only voting members. I forgot to mention that. We don't have a way to separate out people that are not voting members, so. And thank you very much for that. I will let Monica monitor if we have enough. I can't tell the numbers from where I am.
Thank you. So what I'm seeing at this point, we have 23 yeses and 1 no.
That's still a small number of our voting members.
Dr. Burgess, this is Angela. Just a reminder, we do not have all of our voting members in attendance today.
Okay.
I will try to do a head count.
And again, we can put this in the minutes and then distribute that between meetings to inform people that weren't here what we discussed.
And I just refreshed, looking at the same numbers. Sorry, Dr. Burgess, 23 yes, 1 no. We're still at that number.
Thank you. And then I think our next topic of discussion is back to what we were talking about before with Dr. Bridges' presentation, which if we can go maybe to the end of her presentation, our next task is to look at sub-prioritization within Group 1B. And we're not going to decide that today, but she gave you a lot of information about what the groups are in 1B, the population within Idaho of those groups, and then remember the grid that she showed with our priorities. And again, we have not, as a group, decided which priority is higher than another. We just have all of them as equal priorities right now. And I think that's part of our work is to decide when we start to look at these next groups to sub-prioritize, it gets pretty challenging. And if as a group we want to go back and say which of our priorities we want to rank, and if that's going to be how we make our decision, or as she showed you a methodology where you could say, you know, this group hits 4 of the 5 priorities or 5 of the 6 versus this group only hits 2. You know, those are some of the different methodologies we could utilize in going to our next sub-prioritization. So I am going to pause there. We will be doing some email prioritization between the meeting, but this is a big enough decision and a big enough group with a lot of complexities that we may need to do some email voting and then some rediscussion at the next meeting, particularly as I think Dr. Hahn mentioned, we also have our expert advisory commission looking at some of these same things, and we will want to bring that into the mix as well. So I'm going to pause for a minute and see if our chat monitors think there's anything from the chat we want to bring forward.
And Dr. Burgess, this is Elke. I do want to point out to those that are looking at their screen is not the right priority group. So the screen that's up right now is part of our discussion about how many are in Group 1A, but your conversation that you just teed up is for Group 1B. So if whomever is navigating the slides could get back to those that original list on Dr. Bridges' slides, that would be, I'm not quite sure which number it's on, but just don't confuse yourself when you see this slide here.
I think we need to go back around 5 or 6 slides if we can, Carolyn.
Doesn't she have a blank one? Even
Carolyn, what slide do you need to go to, please?
She's not even.
We're 4 slides up from this one. Perfect. Thank you. So, you know, again, as Elke said, we're waiting for ACIP to comment more about the sub-prioritization within Group 1B. We think that discussion will happen, at least in part, on the meeting November 23rd. But we would ask the committee to submit comments about what information, additional information they might need. And I cannot promise that we will have that, but we will certainly look and try find what information we can. We'd also like their opinion about whether there are certain goals or principles that should be weighted more heavily than others, and their rationale for that would be helpful to have. And are there other risks, either of exposure or risk of transmission versus risk of severe disease, or impact on society that potentially should be weighted more heavily? And also, are there other methods that you would find helpful in terms of providing input, such as grids with scores, weighting of importance of goals, or other methods? And just a reminder also that we're very interested in the public comments here, as well as Elizabeth Wakeman stated. Values are an important component of this kind of decision making, in addition to the data. So understanding people's values and helping to make this decision is also very welcome. Thank you.
Thank you, Dr. Bridges. We have covered a lot of territory today, and we will reiterate those next steps as well at the end of the meeting, just to remind you and our timeframes and whatnot that we anticipate. We have one more item on the agenda, if I'm tracking correctly. Thank you, everyone, for your flexibility today and moving around as we've needed to. But the final item on the agenda is the one that would have appeared at 12:55. I'm doing my best to track the timing accordingly, but this is the one about informing others of the advisory committee's work, as you see on the slide here. So I'd like to pass it over to Dr. Burgess and Elke to lead the conversation.
So, again, we are bouncing around a little bit. So what you saw on Dr. Bridges' slide, we will send out by email between the meeting to get your feedback, so we can get you the best information that you need to help with our work on sub-prioritizing Group 1B. Meanwhile, we know that 1A is healthcare personnel, and so we've already done that prioritization. And have you, in the interim, heard anything from your constituents about vaccine distribution to healthcare personnel? Any feedback that you would like to share with us? Anything that we can do better to communicate or get confidence around vaccination? And I will either open that up to raised hands or to the chat. We do have a little bit of time here to review this before we go over next steps.
Dr. Burgess, there are no raised hands at this time.
Okay, thank you.
There's also nothing in the chat as of yet, but people may be typing.
Okay. And, you know,
Dr. Burgess,
things are moving pretty.
Oh, sorry to interrupt. We do have a raised hand from Daryl Anderson.
Okay, excellent. I was just going to say things are moving pretty fast, and we're seeing a lot in the media. So I think we'll start getting more questions if we haven't already. Yeah, Daryl, go ahead.
Thanks, Dr. Burgess. And, you know, I would just say that in the discussions that I've had outside of this group, it seems like it's a no-brainer as it relates to the first parts of these vaccines needs to go to those folks on the front lines in the healthcare arena, and then also the secondary piece being long-term care facilities. That just I've heard no pushback whatsoever. Like, oh, I want to be in front of that line, versus people recognizing the importance, I think, of the frontline healthcare workers that are out there. And then obviously the long-term care facilities, which have gotten a lot of press too. So I think from my perspective, at least in this 1A group, I've heard nothing that says, yeah, we need to make sure that it's something outside of those groups that are in there. So I think the committee's going down absolutely the right path. The question is going to be, how many and when are we, and how many doses will we get, and how quickly will we get them? I think is the bigger question mark that seems to be out there, and nobody has a really firm answer to that obviously yet. It's slowly clarifying. So I think it's good. I think probably the more discussion is around 1B. I would probably say the likely scenario there is there'd be a lot more discussion around the 1B than the 1A.
Thank you very much. Any other raised hands or chat that we need to address?
So there are a couple of comments in the chat. Richard Augustus noted that there are many nurses and hospital-based providers that are still expressing reluctance to be vaccinated. Primary concern is safety of vaccine and lack of information. And a follow-up from Karen Cabell, stated that it would be helpful for the committee to create an education slide deck with details of phase 1, 2, and 3 trials with effectiveness and safety data. And I think we all agree that would be very valuable, and we can make that happen.
Thank you. And I think I have a question to the people that are asking about safety and communication would be the best method to get that information out. You know, we have our vaccine tab on the website, the coronavirus website, and certainly we can put, well, I think our meeting activities go there. We could put information there, and we might need to think about other ways. You know, one of our principles or goals was transparency. So whatever ways we can get whatever information we have out to others, I'm assuming that there will be some federal communication coming out as well. Any other raised hands or thoughts or chat comments before we move on?
Catherine Quinn stated that we can disseminate through regional public information officer groups, which I think is a fabulous
idea. Kathy, I'm sorry, this is Elke. I'm taking over your job because there's another comment from Dr. Peterman, or a statement that 32,000 doses for 32,000 for hospital and clinic staff caring for COVID patients seems extremely low, and that most COVID patients are tested and treated in an outpatient clinic. I don't know if there's someone that can address that question. Comment.
This is Carolyn Bridges. Just to make sure people are aware that first row in the healthcare personnel table of groups for phase 1A includes hospital and clinic staff who are, can't remember the exact wording, but it's hospital and clinic staff caring for COVID-19 patients. So it does include, you know, some of those outpatient providers who are caring for COVID patients. I think what's been challenging is estimating hospital workers is a bit easier number to come by, and estimating the proportion of outpatient clinic staff that fits that category, I think is challenging. I don't know if Chris Carter has any other wisdom to add to that.
Okay, so I'm relying on you folks to let me know if anybody else has their hand up and or anything in the chat. And I think I'm going to just confer with, or have Elke correct me if I'm wrong, but I think we decided that 1B is a complex decision, a lot of categories there, a lot of those principles that we showed you to consider. And so my thought was we were going to send out those questions at the end of Carolyn's presentation to the group by email between meetings, which revolved around what more information do you need? Do you feel like some of our priorities that we should use our goals in a prioritized way to make decisions, and get some of that information between meetings so that we can tee that up for our next meeting and likely have our vote between that meeting and the one after. Is that, Elke, what we decided would be the best way to go?
Yeah, correct. With the understanding, we'll get to more of this too in the wrap up, but yeah, just acknowledging all the comments made about really tough, challenging decisions, things that people, it's a bit anxiety provoking to think about. But things will continually change. We can gauge people's level of discomfort as decisions are made. We'll touch base on that kind of maybe throughout the week, and then at that next meeting, not throughout this next week because it's Thanksgiving week, but the week following, as people are deliberating and looking and thinking about their thoughts on the ranking. But I do want to make sure that for this particular slide that's up, that I know that Katie Quinn chimed in about channels and methods to reach healthcare personnel. And I just want to make sure that we give folks an opportunity to let us know what are the best ways to relay that information. As some of you on here are healthcare providers and represent healthcare organizations, the best way to get that information out. Continue to send us that information. We're always looking for the most effective ways to provide that information. And I'm sorry, I want to touch on one other thing because there have been several comments, some to me personally, and it's also in the chat. Just that several people have asked about the slides, and they will be sent out after the meeting. Now that we've strayed way away from our agenda, we'll roll it back up.
So this is Monica. Do we have any further questions or suggestions on this communication piece, the slide that we have in front of us? Anyone else have any ideas to share? Have there been any additional ones in the chat before we move on from this topic?
It looks like Daryl Anderson's hand is raised. I don't know if that's left over from before.
That is left over from before. I will get rid of that.
Great.
Thank you.
There was a comment about from Randall Hudspeth that as far as nurses go, the Idaho Center for Nursing has a contact list email for most of their 27,000 members, so that will come in handy. And use of professional organizations and boards to help distribute information.
Thanks, Kathy.
Mm-hmm.
So any other
They're
comments?
all great suggestions. Thank you.
Absolutely. So just a quick question, kind of last call for anything on the slide here, either question 1 or 2 on the slide in front of you. Any other concerns that we haven't heard yet about that are being expressed about the vaccine with regard to Group 1A that need to be addressed besides what we've already talked about? And any other strategies for making sure we can promote confidence in both the folks receiving the vaccine initially and then other patients?
Yeah, there's a comment in the chat from Rebecca Coyle that information about how ongoing safety monitoring of vaccines will be conducted would be helpful, and I think that's an important point.
Thank you, Rebecca.
Dr. Burgess, we also have a hand raised from Randall Hudspeth.
Hi, this is Randy Hudspeth. My question would be is if we're going to be sharing this information in our spheres of influence, so to speak, would it be helpful to just get a small number of talking points that come out that are uniform so that we're all giving the same message and knowing that this changes so fast?
I think that's an excellent idea, Randy, and we can work on that. For this group to summarize what we've done so far with exactly the caveat that you said that it may change, but to give updates on as we move along. I love that idea. And I think it was you and someone else that mentioned different professional organizations. They all have their channels of communication. So if we had some talking points, both for those and then the public health information officers were mentioned. I think that's a wonderful idea.
Yeah, there's a huge amount of misinformation going around. And I get a lot of emails.
Oh, you're getting quiet.
I said there's a huge amount of misinformation going around. Yesterday, I got an email that asked, is it true Idaho is getting the first doses because we're a Republican state?
Well, as you know, as we all know, there's a lot of misinformation in so many different avenues, and but it just reinforces the better, you know, one of our goals is transparency. So the better we can get information out that is accurate, hopefully that will help allay some of those misinformations that are out there. But thank you. That I had not heard that. So hear something new every day.
I was
Patrice?
to say, yeah, I think it's true. It makes total sense.
Yeah, I'm sorry. I couldn't tell who was talking.
Yeah, Patrice, I'm sorry. It's Chris Hahn, and I'm sorry for jumping in. I just wanted to also, along the same lines, I know I participate in the advisory committee for immunization practices meeting, and I'll be on Monday. I think Dr. Burgess will as well. Excuse me, Dr. Bridges. I'm looking at Patrice. I'm looking at your name. Dr. Bridges will be as well. Sorry, Patrice is like, whoa, no, I'm not. Anyway, and I'm sure we'd both be happy to make sure this committee is aware of anything that comes out of that meeting, because you know, sometimes there's big news that comes out in the media, but there's a lot of nuance and good information that comes out of those meetings, and we can make sure that gets out to the committee.
Thank you, Dr. Hahn. I think there's two issues. One is making sure our committee stays informed, but I think we can work offline on some talking points to help our committee feel that they and distribute through the appropriate channels as we're moving along, appropriate talking points. I think that are, as Randy appropriately said, that are uniform. I think that's really great. Okay, anything else to be addressed either in the chat or hands raised before we have Monica do our summary, I think. Go ahead.
Yeah, there is a question in the chat, and it's a long one. Has the state or the CDC done any studies on concerns of healthcare workers and the best ways to convey information about the vaccine's effectiveness and safety? This is the first new widely distributed vaccine in most of their lifetimes, so there is not a high awareness of the rigor of the safety protocols that were in place for the studies, and that high standards have to be met before an EUA is given. Are there any speakers that want to?
Before, I mean, I'll defer to Dr. Hahn, Dr. Bridges, or some of the experts, but when I have people ask me about, obviously safety is not necessarily the purview of this committee, other than we do want people to feel good about the vaccine, but these are pretty reputable companies, and even in addition to the FDA review, I'm pretty confident these are companies that wouldn't stake their reputation on something they don't feel good about, but that might not be enough to make people feel comfortable. But I know I feel that these companies aren't ones that are going to want to harm their reputation by putting something out there they don't feel is well tested. But Dr. Bridges, Dr. Hahn, or anybody else have any answer to the question on what the CDC's plan is about communicating effectiveness and safety?
Yeah, I can start with that. I think one of the issues that they have talked about, of course, they have their public ACIP meetings that Chris Hahn mentioned that talk a lot about the safety systems out there that have been in place for many, many years. Although we haven't had a vaccine that's been new, that has this kind of profile, certainly, we have had a number of new vaccines over the last several years, such as Shingrix vaccines, or the meningococcal vaccines, for example, high-dose flu, adjuvanted flu vaccines, etc. And so what I've tried to convey and talks that I've given is the multi-layered systems that we have in place. It's not just one person's decision about safety. It's multiple committees, multiple independent bodies, not just government entities, that provide that evaluation for safety and effectiveness, and that will also be discussed in public meetings at the BRPAC meeting that was mentioned as well as at an advisory committee, immunization practices. CDC has a lot of communications materials that they are preparing to send out once there is, some decisions about these vaccines. And I think that the companies have been incredibly transparent, to a much greater degree than they have been allowed to for previous kinds of products. And I have a lot of information up on their website, so I'd encourage people to look at that as well.
Thanks, Carolyn. This is Chris Hahn. Nate Thompson put a really nice FDA link, which I go to all the time, about emergency use authorization in the chat. I think that's something that people are even less familiar with than the routine. So that's another great resource. And I'll just also add that, the CDC and we are talking a lot about, in fact, this part of this conversation is about asking you all for your thoughts about how to convey information about the effectiveness and safety. It's challenging because we can't put materials together till we have that information, right? So it's going to be a really tight timeline once that information is fully available.
Dr. Burgess, we do have a hand raised from Matt Bell.
Excellent. Go ahead, please.
Yeah, thanks. I was just going to mention that, I can't speak for all of the carriers in the state, but Pacific Source certainly will be communicating with most of the providers that we have contracts with about, things like vaccine administration. When we get guidance from the federal government on vaccine administration and costs and those kinds of things, we typically communicate that. And, I think I could talk to the other carriers and we could include, the talking points with our provider communications, in addition to however we communicate through professional organizations.
Great. Thank you so much. All right. If I don't hear any more chats or hand raisings, I think we are pretty close to wanting to get to our summary and wrap and next steps. And Monica, is that you?
I believe it is. Thank you. Thank you, Dr. Burgess. I just wanted to make sure that we had covered everything in the chat. I've been kind of looking at it as we've been going through too. And of course, in the meeting notes, we'll make sure that we document just as much of that as we can and summarize it for you, including the answers that were given. So with that, and before I forget, I was going to ask in the beginning of the meeting, if anybody is not receiving emails from me with the meeting package materials, which usually includes an agenda, the report from the previous meeting, please reach out to me just in case there are any communications not getting through to you to make sure that everyone has everything they need. So thank you everyone for your flexibility as we have moved through this meeting, which is absolutely required as we're leaning on technology to drive our meetings these days. So thank you everyone for that. So let me see if I can trace our journey for today. We started with sharing the goals, principles, and healthcare personnel rankings. That's Group 1B that we've been working on the last couple weeks, and we had the final pieces on those 3. And then we jumped down to hearing from Dr. Bridges on the COVID-19 vaccine updates and our new information to get us ready to consider our next subgroup, the 1B subgroup. So lots of things to consider there. We had Elizabeth Wakeman speak to us about some ethical considerations as well. So lots of good information for us to consider there. Then we were able to move back up into the agenda to hear about double checking here, the regional vaccine dose allocation. So get an update on that. And then the voting members were able to weigh in on the question of agreement with the distribution plan by district, I believe it was. And on that, we're heavily weighted on a yes vote there. So thank you for that, everyone. Then we went on to have this discussion that we just finished up on communication with first our Group 1A folks, and then of course we'll be continuing to look at this and consider this for all the groups to make sure there's good, accurate, consistent information going out to everybody to help support the efforts here. So thank you everybody for your suggestions there and your great ideas. and we'll be continuing to gather feedback from you moving forward. So with that, let's move to action items and next steps. And I might need a little bit of help here because I want to make sure we're still on track given what we discussed today during the meeting. So initially, our first step was going to be asking all advisory committee members and the public, of course, to invite or to submit written input for consideration on the prioritization of subgroup 1B through the respective email addresses we have to organize the information coming in. And of course, and then we were hoping to receive that by Tuesday, the 24th. So that would be next Tuesday, close of business. And then like before, we want to make sure all those perspectives are being heard and considered in decision-making as we move forward. So all of that will be compiled and sent to all advisory committee members, as well as any additional information that becomes available from CDC for review by just before Thanksgiving. So that would be Wednesday. So that's a quick turnaround and a lot of information to consider because we know that you'll have lots of time to do that on Thanksgiving the following day. Just kidding. We have a quick turnaround, but we want to make sure you have that information so when you do have the time available, you can review it. Now, I just wanted to check in with our chair and executive secretary on number 3 here. As we talked about the complexities related to ranking Group 1B.
Yeah, I was just messaging Elke. I think we originally were hoping to get this vote done between meetings, but realizing the complexity of this group, I think we had asked that we do what you put in bullet 1 is get all the input that we can and then review all of that, and then maybe next meeting talk about whether we need to use our goals, rank our goals to help us rank that 1B group. Is that how you were seeing it, Elke?
Slightly different.
Okay,
so
fair enough.
I think we were talking about there's a lot of information coming. And that we just like the number 1 and 2 imply that we'll send you everything we have. We've gone through this information. Just given the nature of the rapid pace of all of this, we had discussed still trying our best to take the information that we're sending to you and comments received, any information that comes from ACIP, which ACIP could be just, in all transparency, the derailer that sort of changes the trajectory if they choose something completely different. But knowing that this is a huge challenge, still trying to bring you all to giving your ranking by the time we come together for our next meeting in December. So we are making that request. You go through that process. And then when we get together on December 4th, given that there's a lot of things that could change and it is a challenging directive that we're asking, if it's just a level of discomfort that is too much, then we can kind of pivot when we get together on the 4th and do something different. But we do kind of want to instill this practice of making these fast-moving, challenging decisions, but with the respect and understanding that Group 1B it's going to be a tough one, and information can change. So I think that's where apologies to everybody on the committee. There's been a lot of back and forth and changing information, so we wanted to clarify that.
Excellent. Well, thank you for that. And I guess this underscores the importance of everyone. Please do submit all of that input so that it can be fully considered as our members and voting members work toward ranking this next group. It's very, very important that we hear all perspectives so that they can be considered. And I'm sure I don't have to remind everyone to make sure that all of that information is reviewed in detail so that it can all be incorporated into our decision making. So thank you everyone for that. And thank you, Elke and Dr. Burgess, for clarifying our next steps in this challenging next phase of our work together. With that, if we could take a look at the next slide, and we will email you and remind you of these next steps as well. But in terms of our next two meetings, we're going to continue for now with the understanding things might change as we've heard throughout the meeting, but we're going to be continuing with our next meeting on December 4th, as you've heard, and then Friday, December 18th, 2 weeks from then for our other December meeting. So that's our plan for now. And with that, I think that's all for me today. And I'd like to pass it on back to our chair, executive secretary, to close us out for today.
Yeah, thank you guys again for your patience today. We had to make some last-minute changes, and so I know that can be challenging, and thanks for hanging in there with us. I know we ran over last time, so we might end a couple minutes early this time to make up for that. And please watch your email for the summary and for the request, again, for your feedback on what information is helpful to you, and also for your voting on any questions that come out by email. And then we will work on the talking points that might be a evolving document, because like everything with COVID, things continue to evolve, and we anticipate eagerly what happens with the advisory committee meeting on Monday, and we'll possibly need to do a little bit of adjusting if they come out with anything significantly different than the direction that we've been heading. So thank you again, and I'll turn it over to Elke.
Great. Thank you, Dr. Burgess. For me, just as last time, a huge thank you on behalf of the department. We know we're asking a lot. We know what we're doing, what we're asking is also challenging. We got to role model what it means to pivot constantly as we ran this meeting through. But just we ask for your patience also as we learn, we get you information. If there's some major concerns or issues that you have about this approach that we're taking, please let us know. We want to be respectful of how you all are feeling and wanting to address this, and at the same time acknowledging the fast pace that we have to maintain. So with that, I will turn it back to Monica.
All right, everyone. Thank you very much for our closing remarks. And with that, I believe we're adjourned for today. Thank you, everyone, for being here today.
Thank you.
Bye-bye.
Natalie?
Yes.
Hello.
Hello.
I'm gonna wait a few more minutes until
Okay.
everyone's off. I have saved the chats. Actually, what else did we need to do? Save the chats.
We would have needed to save the. Oh wait, no, the
Recording. I'm sorry.
Yes, the recording.
Angela's here in front of my desk. I've got Natalie. I'm gonna come talk to you in a minute. Okay. We do need to create the. Hold on, I'm gonna put you on mute for a sec. Hey there. So I see we still have Sarah. We have a couple people.
Yeah, I can call you if you want.
Yeah, let's do that. Oh wait, I wanted to have you look at something really quick. What slide do you see right now?
I see wrap up closing marks with Dr. Patrice Burgess.
Okay. Now which slide do you see?
So yeah, it didn't change.
Same one.
Because you don't have the presenter role.
Very good. Okay, I'm going to call you on the phone.
Okay, cool. Bye.
Okay, bye.